So let's kick off now with my good friend, Prof. Osman. Can you please explain, Prof, what the ESC guidelines, the current European Society of Cardiology guidelines, state about this important topic?
Thank you very much indeed, Yasser. It's a pleasure to be here with you talking about the ESC guidelines for atrial fibrillation. So I'm a cardiologist and electrophysiologist here at UHCW in Coventry, and also working with Warwick University. So the European Society of Cardiology guidelines for atrial fibrillation are a very, very comprehensive and useful set of guidelines. The ESC have really provided guidelines over the last 15, 20 years and have regularly updated them. And the last update was in 2020. And one of the things that's actually very helpful about the ESC guidelines is that they are updated very, very regularly. So it would be interesting, I guess, to find out how many people are aware of these guidelines.
Yeah, let's have a poll on that. So if we can have some interaction from the audience, how many of the audience are actually familiar with the latest European Society of Cardiology guidelines on AF? And if you look below your video player, you should have the option to give your answer, and we'll give you a few minutes, not a few minutes, a few seconds to input your answer, and it'll be quite interesting to see what the results are. Faizel, while we're getting these results, can you explain to the audience how you perceive the European Society of Cardiology guidelines? I mean, a lot of cardiologists I speak to tend to use them as a sort of reference guide. In your opinion, is that correct use of them?
Yeah, that's a very good question. I agree. I think they are a very good reference guide. There are other guidelines, of course. Here in the UK, we have the NICE guidance as well that's been updated recently. I think the beauty of the European Society of Cardiology guidelines is that they are updated frequently. They incorporate all the latest data, and it's a pan-European, very often American specialty that that actually makes up the core of the people that write these guidelines. So for me, I would say they are the gold standard.
Fantastic. So let's see what the audience have inputted in terms of their familiarity with these guidelines. Can we get the poll responses up on the screen? What? Nope. Have we got the results? Have we got the results? Yes. So I can't see those. Is that 100%? Yeah, so 100%. It seems like 100% of the audience, Faizel, that's quite reassuring, are actually familiar with these guidelines.
Yeah, no, that is very, very reassuring. Absolutely,
Fantastic.
absolutely. And Pat. And so now that will hopefully make life easier. So I'm just going to run through some of the background around atrial fibrillation. So the audience out there, and will be very familiar with some of this data. We know that AF is the commonest arrhythmia worldwide, and certainly in the Western world. We also know that the prevalence and the incidence of atrial fibrillation is rising. So over the coming several decades, we are going to see more and more atrial fibrillation. As you quite rightly pointed out, AF does increase the older we become. It is more common in males, but females also have a slightly higher risk of stroke from atrial fibrillation. And something that's quite startling is that if you're in your 50s and you're in a room full of people, there are 3 of you in total, there is a 1 in 3 chance one of you will get atrial fibrillation. And that's quite startling when you put it in those terms. So it really is an arrhythmia that affects the whole community, and we are going to see more and more of this arrhythmia. In terms of the classification of atrial fibrillation, this really has remained fairly unchanged over the last several years, and we have the classification of paroxysmal, where AF comes and goes by itself, usually lasting no more than 7 days, typically terminating within 48 hours. Persistent is where atrial fibrillation lasts beyond 7 days. Long-standing persistent atrial fibrillation is where AF lasts for more than a year continuously, and permanent is where it's accepted that the patient has atrial fibrillation, and both the persistent atrial fibrillation, and both the patient and the physician have accepted it, and it's there all the time. time. There is this entity of first diagnosed atrial fibrillation, and patients can, of course, have a first presentation with either paroxysmal, persistent, or permanent. There are certainly certain terminologies that are now not used as much, and the guidelines suggest that we should perhaps avoid them. And they are terms such as lone AF, valvular, non-valvular AF, and chronic AF, because they do generate some confusion. So why is AF important? And again, you very nicely highlighted, Yasser, some of these. We know that patients can present with symptoms, and that impacts significantly the quality of life. Typically palpitation, breathlessness, fatigue, but other symptoms can also occur that can result in hospitalizations. Importantly, a significant number of patients can be completely asymptomatic, so they can be at risk of all the problems of AF and not even realize they've got it. And that case that you highlighted of the lady who had a devastating stroke, again, if somebody has AF not realizing it, that can be potentially life-changing. We know that AF is associated with some very negative outcomes. There is an increased risk of mortality. We know also that there's a higher risk of stroke in these patients. We know that there's a risk of LV, left ventricular systolic dysfunction, and heart failure, increasing recognition of dementia and cognitive decline. There's also depression because of the symptoms and the quality of life that is impacted. Patients having recurrent admissions to hospital and hospitalization, and that's a huge part of it as well. And of course, that is a huge burden on the finances of healthcare providers as well. So all of those things are very, very important. Yes, sir.
Okay, so that's really helpful. You mentioned, Faizel, I can't help asking this question, that there's certain terminology we shouldn't use. In primary care, I often see this terminology of AF resolved, or this read code of AF resolved. Can you truly resolve AF, particularly when it comes to stroke risk?
So that's a very good question. I think atrial fibrillation, it's a spectrum of a condition. So very often starts as paroxysmal and then can transition into persistent. And clearly there are things we can do to delay that or slow it down, or to try and prevent it from recurring back. However, as you'll see in the coming few slides, atrial fibrillation, sadly, is a condition that becomes more common the older we become. And as the heart becomes older, develops more fibrosis, becomes a little bit more dilated, atrial fibrillation is likely to come back. And there are several things you can do. There are medications we'll talk about. However, the risk of atrial fibrillation is always there that it may come back. So I always hesitate to use the word cure atrial fibrillation. I prefer the word treatment rather than cure.
Fantastic. And you mentioned that the ESC guidelines update very regularly, far more regularly than perhaps our national guidelines. What's new in the latest iteration of the ESC guidelines in relation to AF management?
So you're right. The European Society of Cardiology do update the guidelines much more frequently, and I think that's a very helpful thing to do, because it takes into account up-to-date trial evidence, and actually that can be incorporated into practice. So in the 2020 guidelines, there are a few things that are new and that have been updated. I've tried to highlight here in red. So the ESC recognized that atrial fibrillation now can often be diagnosed by patients themselves, because nowadays people have smartphones, smartwatches, smart devices, even blood pressure monitoring devices that can record heart rhythm. And they often have a single channel recording. So in the past, we'd certainly say that atrial fibrillation, you'd need a 12-lead ECG, but recognize now that actually you can diagnose atrial fibrillation from a single rhythm strip, and the guidelines talk about having 30 seconds or more of an irregular rhythm with no regular atrial activity or P wave that is seen, and that can be diagnostic of atrial fibrillation, and that's very, very important. So this slide just shows what sinus rhythm would look like. You have clear atrial activation, a clear P wave before each QRS complex, and the QRS interval, the RR interval, is regular. However, in atrial fibrillation, there are no discernible P waves, and the QRS activation, the RR intervals, are completely irregular, and that is diagnostic of atrial fibrillation. So what else is new in the guidelines? So I think very helpfully, the guidelines now also talk about risk factors for atrial fibrillation. And these slides highlight some of the risk factors that can be associated with atrial fibrillation. We know that there are some things that we can't do anything about: aging, genetics, male gender, and ethnicity. However, there are a lot of things that we can do something about. So patients who have comorbidities such as hypertension or diabetes, people who are overweight or obese, we know that impacting, controlling those things and improving those things can have an impact on the atrial fibrillation. Other things such as obstructive sleep apnea, and there's a lot of recognition now that obstructive sleep apnea is associated with atrial fibrillation and can be. Alcohol and smoking, again, lifestyle choices. It's important that everyone is aware that these things also impact your outcome in atrial fibrillation, and hyperlipidemia. So again, a recognition there are a whole host of things that we can do something about to reduce the risk of atrial fibrillation. Now, the guidelines also talk about identifying lifestyle changes and tackling weight issues. We also know that, particularly when it comes to atrial fibrillation ablation and treatments, the risk of recurrence is higher if these risk factors aren't tackled. And the guidelines now talk about tackling those risk factors, particularly when it comes to therapies such as AF ablation. And there's also a recognition that actually opportunistic screening can also be very, very helpful and very useful when we're talking about atrial fibrillation and ensuring that we try and identify those particularly at risk with opportunistic screening, particularly those that have hypertension. So we know, as I've touched on previously, that there are a number of screening tools that are available. We're all now wearing a lot of devices. I have an iWatch now, not that I'm advertising for Apple, but we all have devices that we're wearing. We have smart watches, smartphones, and we are going to be picking up more and more atrial fibrillation. And again, the guidelines recognize that actually there is going to be a higher awareness by patients. And they talk about opportunistic screening in people who are 65 or more, and perhaps having a more systematic approach in those that are 75 or more, where we know the risk and the complications associated with AF are higher. We know, obviously, from the guidelines that to make a definite diagnosis of AF, you need a 12-lead ECG, but the guidelines recognize that with these new devices, that often it'll just be a single-channel ECG recording. And again, they very usefully have said that actually 30 seconds or more of something that looks like atrial fibrillation is then enough to diagnose atrial fibrillation. And so with that, I'll hand back to you, Yasser.
Yeah, well, Prof, I mean, let me put you on the spot. Are you happy to make a diagnosis of atrial fibrillation with a trace that a patient has recorded in their living room, a good quality one-lead ECG trace, 30 seconds of atrial fibrillation? Is that enough for us and for you to diagnose atrial fibrillation to the point of perhaps starting anticoagulation?
A very good question. I think the answer to that, Yasser, is yes. I think the key word that you used there is good quality tracing. So if there is a tracing that is actually not good quality, and you can't actually make any head or tail of what's going on. The key thing is you have a good quality tracing. You have 30 seconds of it. You can clearly see that there is irregularity in the RR interval that is throughout that 30-second period, and actually that there is no discernible underlying P wave. And I think based on that, you can, I think, confidently say that this patient has had an episode of atrial fibrillation. Now, clearly, if it's persistent, you can confirm that with a 12-lead ECG, but you won't always have that, of course, and patients may have paroxysmal atrial fibrillation, where the AF terminates and you just don't see it again. So I think if you have the technology, you can capture that rhythm at the time of the symptoms, and it is a good quality tracing and conforms with atrial fibrillation as defined by these guidelines, then absolutely yes.
I mean, that's fantastic. That's really going to open up the scope for picking up a lot more incidental AF, which is actually moves me on to the next question. A lot of these devices are going to pick up AF that's completely subclinical, patients completely unaware of that rhythm. How do we manage those patients? Is the management different in those patients?
So again, another very, very good question. So the management of atrial fibrillation is also very, very clearly laid out in the new ESC guidelines, and they have quite a nice 4S approach. That these slides are taken straight from the updated guidelines, and they talk about the 4S approach. The first being stroke prevention and assessing stroke risk using the CHADS-VASc scoring to assess symptom severity. So how bad is the atrial fibrillation using some sort of symptom scoring. The guidelines talk about the European Heart Rhythm Association symptom score or some sort of quality of life assessment. Assessing the severity of the AF burden. So how often is the AF happening? How long is it lasting for? What are the temporal trends? Is it paroxysmal? Is it persistent? Is it long-standing persistent? And the final S is substrate severity to try and gauge an idea of the underlying substrate. Is there an atrial cardiomyopathy? And very often comorbidities are important when assessing that, such as hypertension. And several clinical assessments using history and examination, but also imaging such as echo, CT, MRI can help with that substrate assessment as well. And again, when we talk about integrated management, I think these two slides are very, very helpful. They show very clearly that the patient is at the center of what we're doing, or at the top of the pyramid, that it's very important that we think about the important things, stroke prevention. The case you very nicely showed at the start of this this webinar was of a lady who had a devastating stroke. So stroke prevention is something that we should immediately be thinking about. And of course, along with that, symptom control and management of cardiovascular risk factors and comorbidities. And all of that requires, of course, buy-in from the patient, educating the patients, talking about lifestyle modification, and actually having some possible psychological management as well, because that can help. And then having strategies working with the patient to ensure that they adhere to those therapies. And having a multidisciplinary approach where people like cardiologists, like general practitioners, AF nurses, even carers and people who look after patients with AF, as well as pharmacists and community healthcare professionals working together and having input from other subspecialties from around them to actually tell us to manage the patient and have them at the center of the focus. Coming on to the updates within CHADS-VASc, again, I'm sure the audience are very, very familiar with the CHADS-VASc scoring. Just to highlight that another new thing within the ESC guidelines, the C of congestive heart failure, of course, was always a clinical history of heart failure or echo evidence of LV systolic dysfunction, but there's a recognition that hypertrophic cardiomyopathy is also associated with a higher risk, and that is now incorporated within the guidelines. The guidelines also talk about the HAS-blood risk, which again, people will be very familiar with, which assesses the risk of bleeding. And they also touch on the NOACs or the DOACs that are available and talk about the type of DOACs and the doses that can be used, again, based on all the evidence that is available. And who should be anticoagulated? Well, the answer is almost everybody. If there is a female patient who has a CHADS-VASc score of 1 and it's because she's female, then you don't need anticoagulation. If your CHADS-VASc is 0 and you're male, as it will be, you don't need anticoagulation. But if your risk score is 1 and you're male, you should certainly be considered for anticoagulation. And if your score is 2 or more and you're a female, you should certainly be considered for anticoagulation. So again, a push towards getting clinicians, healthcare providers to think about anticoagulation to prevent the devastating impact of strokes that we can come across. So the other thing you asked about was these subclinical features or atrial high rates. And increasingly now, patients have these devices. They may have implanted devices such as pacemakers or defibrillators, which can obviously pick up atrial arrhythmias within them. And it's a very good question that if you don't quite meet the criteria for atrial fibrillation, then actually, what do you do about those patients? And again, the guidelines do touch on that. So subclinical atrial fibrillation or atrial high rate events, as you can see on these slides, they can be difficult to manage. And how would you manage them? Would you start anticoagulation? And again, the guidelines have very usefully talked about that such scenario and how we would manage those patients as well. And they talk about assessing the CHADS-VASc score, which of course we're all used to doing, and trying to assess whether the patient's at low, moderate, or high risk based on CHADS-VASc, but also then looking at the AF burden or the subclinical AF burden or the atrial high rate burden. So how often is the patient having these episodes of subclinical AF or atrial high rates, and how often are they lasting for? And clearly, if the burden is high and the CHA2DS2-VASc score is high, then there is a higher push towards actually giving oral anticoagulation. I hope that answers the question. Yes, sir.
Yeah, fantastic, Faizel. You mentioned what I want you to move on to now is sort of a brief overview of some of the new trial data. I know there's been some very impactful trial data, particularly in relation to AF intervention with ablation. But you did bravely mention, Faizel, as an EP cardiologist, as a professor in EP cardiology, you still aren't in a position to tell patients there is a cure for atrial fibrillation. So if you could clarify what exactly is the role of AF ablation in the management of atrial fibrillation. And if you could also answer, from a primary care perspective, a really important question: which patient should we be thinking of referring to you for an assessment for an AF ablation?
Thanks for that, yes, and a very, very important questions that you asked there. So in terms of the trial data, there have been several trials that have been published that have sort of come along in the last few years that actually have been very important, and I've listed a few of them just on the slide here. So Castle AF was a catheter ablation for atrial fibrillation in patients with heart failure, and they had implanted devices in. And essentially what the study found was that these patients with heart failure who underwent an AF ablation procedure had very beneficial effects. They had mortality benefit, and this was the first time that an AF ablation cohort actually showed a mortality benefit. So that was quite an important study published just a few years ago. There were two other big studies that have been published. The Cabana trial is an American trial, a large randomized multi-center trial looking at the effect of catheter ablation versus antiarrhythmic drug therapy on a number of outcomes, including mortality, stroke, and bleeding. And the study actually found that the arm that had AF ablation, this trial didn't reach the composite primary endpoint. However, they recognized that the actual event rate was very, very low in the trial, and there were also some issues of crossover between the two arms within that study. The latest study really that's shown here at the bottom is the EAST trial, which is early rhythm control in patients with atrial fibrillation, which was published just very recently in the New England Journal of Medicine. And this study, again, a large multi-center randomized controlled trial, primarily within Europe, that looked at early intervention, be that with ablation or with drug therapy, of having an aggressive early rhythm control strategy, and found that actually the patients did do better with that strategy. So again, evidence suggesting that rhythm control actually is important. In terms of what the guidelines say of who should be having an ablation or who should be having drugs, I think these slides can be very, very helpful for us. Again, it's interesting to note that patient choice is actually high up there, no matter what therapy we talk about. So it's important to have that discussion with the patient in front of us, assessing their risk factors. And again, risk factors are highlighted here, as well as their comorbidities, ensuring that they're on the correct therapies, ACE inhibitors, ACE receptor antagonists, and particularly treatments for hypertension or for LV systolic dysfunction. Now, patients who have no or minimal structural heart disease, antiarrhythmics can be tried. And again, we normally start with the class 1 antiarrhythmics, drugs such as flecainide or propafenone. We also have dronedarone, which is a newer class 3 drug that's used in selected patients as well. But catheter ablation is an option, again, after discussion with the patients. Those that have preserved heart pump function but have coronary disease, again, the drugs that you're kind of limited by then are drugs such as dronedarone and amiodarone. Amiodarone, of course, is the most powerful antiarrhythmic, but is associated with some quite nasty side effects both in the short and the long term, and may not be an option really. A catheter ablation also can be considered in this cohort, and those who have heart failure with reduced ejection fraction, where the LV systolic function is significantly impaired, their catheter ablation or amiodarone, and again, a close discussion with the patient about what they would prefer themselves. And again, the key thing around ablation is that discussion with the patients. we always highlight to the patients that the reason for doing an AF ablation is to improve symptoms. So you have a patient who's in AF, they feel far better in sinus rhythm than they do in AF, but keep going into AF despite medical therapy. That may be with or without amiodarone. And there, a discussion around ablation can be very important, and particularly also in younger patients who may not want to take nasty drugs such as amiodarone, or who are taking antiarrhythmics such as flecainide, but actually don't want to take flecainide longer term. And we know from the evidence that actually AF ablation can be particularly helpful in those patients. And currently, we have two broad ways of performing an AF ablation. And essentially what we do know is that the pulmonary veins that drain blood from the lungs back into the top left chamber, the left atrium, have sleeves of muscle tissue within them that fire off ectopic beats, which then triggers atrial fibrillation. That was really discovered in the early to mid 90s. And an ablation procedure involves putting in either a single piece of kit, a balloon with a wire that comes out, pushed against the vein, blocking the vein, inflated up, and that then freezes the outside of the vein. And that freeze generates a scar which seals the vein electrically, so the signals cannot escape back out. The alternative is using point-by-point radiofrequency ablation, where we're burning tissue, and typically we use a 3D mapping system to do this. So we're putting two wires into the left atrium, into the top left chamber. We're seeing the signals within the pulmonary veins, and we are burning outside the pulmonary veins around them in pairs, usually, to seal them off. And that scar that's generated by the burning this time also prevents the electrical signals from getting out. And the success rate can vary, of course, between the type of atrial fibrillation. Those with paroxysmal atrial fibrillation usually have a higher success rate in the region of 70 to 80% with one procedure at 1 year, whereas those with more persistent atrial fibrillation tend to have lower success rates, because we know that the AF can potentially come back, and we tend to quote a 50 to 60% success rate at 1 year. And some people do need to come back for more than one procedure. But again, having a very individualized discussion with them and looking at them is very, very important in talking about risks of ablation. I've just shown a slide here of a paper that we've just recently published looking at the safety and cost effectiveness of day case catheter AF ablation, which is what we've been doing in Coventry for a while, and many other authors around centers around the world have published their data as well, very much in keeping with ours, showing that this is a very safe, effective, and a cost-effective way of managing patients who have atrial fibrillation, and actually can provide a significant benefit for them. Again, when we look at the detail of some of the guidelines, it all comes down again to patient choice, and this slide tries to differentiate between those that have major, minor risk factors, and also recognizing the Castle AF trial, that those with heart failure with reduced ejection fraction, thinking about an AF ablation in those selected cohort of patients earlier. But catheter ablation, you can see, is dotted around these slides. And in terms of primary care, which is you asked about specifically, I think, again, a discussion with the patient around quality of life and symptoms and the medication they've tried. And I think early referral on, ideally, to electrophysiologists such as myself, I think is quite important, because what we do know is that the earlier we perform an AF ablation in that AF journey, the more likelihood that they will have success at 1, 2, 3 years down the line. So an early intervention is better than one that is delayed, because over time the atrium can develop an atriopathy, and then maintaining sinus rhythm can be more difficult. So really, this is a summary slide showing the AF guidelines really in a nutshell, highlighting that the patient is at the center with all the various primary and secondary care healthcare providers around them, and the guidelines very much advocating a CC to ABC approach. CC is to confirm AF with a 12-lead ECG or a single channel recording, to characterize the AF using the 4S approach that we've talked about, and then having an ABC approach of ensuring that there is anticoagulation, and we think about stroke risk, of ensuring that we control the symptoms so that patients' quality of life is considered, and rhythm control, rate control are also considered and discussed. And then thinking about comorbidities and risk factors and tackling those for each patient that's in front of us. And
Faizel,
with that, I'll hand back to you.
What can I
So,
say?
thank you.
Yeah, what can I say, Faizel? That was a masterclass overview of the current evidence, and really brought us up to speed with the current guidelines in atrial fibrillation. I think the two things that stood out for me were really, the most important stakeholder in this whole piece is the patient, and we've got to have the patient right at the center of that decision-making process. But also, if we are considering intervention, I think it's really important to remind ourselves, you reinforced it beautifully, that the earlier you intervene, the better the outcome. So if you are going to if you're thinking a patient maybe benefit from an intervention, let's get that referral done early. Before I let you go until the discussion at the end, Faisal, you mentioned that you can't cure atrial fibrillation. So what you didn't do actually was define what you mean by a successful ablation. What does success mean in terms of an AF ablation procedure?
So that's a very good question. So when I say I don't use the word cure, a cure implies that you've done the procedure and the AF will never come back again. It's gone for good, and I would say that's not usually the case. And we know that as the heart ages, as I've mentioned, as the atrium dilates, the risk of atrial fibrillation coming back is there over time. Now, what we're doing by doing an AF ablation is actually minimizing that and actually maintaining normal rhythm for a lot longer. And so in terms of success rate and how we would define success rate, we would look to make sure that the pulmonary veins are isolated as a first off procedure. And again, in those with paroxysmal atrial fibrillation, where we know the veins are the triggers of the atrial fibrillation, if we've isolated the veins, we know the outcome's actually very good and the success rates tend to be quite high. We tend to quote here in Coventry a 70 to 80% chance of success at 1 year. And actually, for paroxysmal AF, we know the outcomes are around about that level. However, those with persistent AF, what tends to happen is that the veins, of course, are important, but then the atrium itself can become important in triggering and maintaining atrial fibrillation. And so if you're just isolating the veins themselves, you're not necessarily going to be preventing that AF from coming back if you have recurrent persistent, particularly if you have long-standing recurrent persistent, where other parts of the heart, the atrium, can become important. And we often will then, if they come back for further procedures, we'll make sure the veins are isolated because they can often reconnect over time, and that just happens within the normal heart. But we will often then do other ablations within the heart, near the roof of the heart or the back of the heart. And there are certain areas that are a little bit more difficult for us to do ablations on because they increase the risk of complications. But really, in terms of success rate, our first off procedure is to isolate the veins to make sure that they are electrically sealed and there is a good pulmonary vein isolation, or PVI, done at the very first procedure. When they come back, to ensure that the veins are isolated, and if any further ablation or burning needs to be done, we then target that.